Hello, everybody. Welcome to another in our Peers Under Pressure series. Many of you will know of us here at OSCE, and of course, if you've joined us previous webinars, you'll also know some of my guests this afternoon. But for anybody that's new to OSCE, welcome. So without further ado, let me introduce you to my guests. I'm delighted to welcome 4 experts in their field. So firstly, a very warm welcome to Dr. Zena Aldridge. Zena is a mental health nurse specialising in dementia care with over 25 years of experience working across health and social care settings. She holds a portfolio of roles, including regional clinical advisor for dementia, consultant editor, nursing older people, and is also an honorary visiting researcher at both Newcastle University and the University of Bradford. I'd also like to welcome back Alison Schofield.
Hello, everybody.
Alison is clinical manager and honorary TVN at York Hospital NHS Foundation Trust. Her current role as clinical manager at Mole Digital involves producing and delivering education and tools for healthcare professionals in all aspects of tissue viability. She's worked for more than 20 years in community services as a district nurse and a tissue viability nurse, and she also led a pressure ulcer prevention team in Bradford NHS services. I'd also like to welcome back Carol Young.
Hi.
Carol was the lead tissue viability nurse specialist at Cambridge University Hospitals NHS Trust for more than 20 years and working on a number of regional and national initiatives. She is also an associate lecturer at Anglian Ruskin University, teaching tissue viability related clinical skills for pre-registration student nurses. And last but by no means least, I'd like to welcome Anita Morton.
Hi, everyone.
Anita has more than 20 years experience in community nursing, teaching and industry, coupled with an extensive background in nurse education, pressure area care and negative pressure wound therapy. Anita truly believes that education is the key to excellence in care. And I'm Emma and I will be your chair today. We want you to get as much out of today's session as possible. So if you'd like to share your experiences or ask any burning questions, please use the Q&A function on Zoom to participate in our discussions. These ladies truly are experts in their field, so this is a great opportunity to ask the expert. Okay, so with our introductions done, let's get on with our session. Preventing pressure ulcers in people with dementia. What are the challenges? Zena, let me come to you first. We know that patients with dementia are more at risk of pressure ulcers and tissue breakdown. So let's explore why this is.
Absolutely. Good afternoon, everyone. Let's give you a bit of context to this situation. And one of the first things we need to address is the number of people that are living with dementia in the UK at the moment. And as you can see from that first slide, it's a huge amount of people. We're talking in excess of 900,000 people are currently living with dementia in the UK, and a large percentage of those, in excess of 590,000, are living with advanced symptoms. And that's really important. As we go through, you'll understand where that relevance is in terms of where we link it with pressure ulcers. And you can see that the amount of people, not only in the UK, but living worldwide, is going to grow year on year over the next 30 odd years and beyond that. So this is going to be a problem that's going to be more and more common to us. And almost 40% of people who live with dementia, particularly with those more advanced stages, are likely to develop a pressure ulcer before their death. But even those people in the earlier stages may be more at risk because of some of the functional deficits that they have. And as you see, not only are people with advanced dementia likely to get pressure ulcers, they're more likely than other people of the same age with other conditions who don't have dementia. Next slide, please. So when we talk about dementia, it's really important that we kind of break a few myths down about what dementia is and what it isn't. And I think there's been a lot of misnomers over the years where people think that dementia is a problem with memory loss. And whilst memory loss might be part of the jigsaw, it's not the only part of the problem for those people affected by dementia. And dementia is not a mental health disorder, as it's often considered, because diagnosis often happens in mental health organisations and memory assessment services. It is a neurodegenerative process, and if someone only has memory loss, it's unlikely it's dementia. They tend to have memory loss and other components of neurodegeneration, so they might have issues with problem solving, with communication, language, all of those kind of things. So it's often good to know that, so you can reassure people who might be presenting with some age-related memory loss. If they don't have any of those other issues, then it's unlikely that it's going to be dementia. But there are 4 main types of dementia that affect most people. And then you can see there from the screen, it's, the 4 most common types of Alzheimer's disease, vascular dementia, and often we see a presentation where people have mixed symptoms. So they have some Alzheimer's disease presentation, some vascular dementia, so that they might be diagnosed with mixed dementia, dementia with Lewy bodies, and frontotemporal dementia. Now, I'm going to just give you a brief overview of some of the differences, because it's really important to understand that having that diagnosis of not only dementia but the type of dementia is really helpful in identifying what some of the risk factors might be and some of the symptoms might be. So having that key information is really important. I always say, we wouldn't put in someone's notes that they have cancer without understanding what type of cancer they had. What we'd want to know is, what type of cancer they've got, because that would give us an indication of what their symptoms might be and what their needs might be, and dementia is no different. Next slide, please. So Alzheimer's disease is the most common, and often it's a very subtle change to start with. People might be forgetting appointments, names, just the mood might change slightly, and it'll happen very slowly and progressively over a period of time, which means that often those early symptoms are not recognised by the person or those around them, because they are very, very subtle. Vascular dementia is the second most common. And actually, the risk factors of vascular dementia are very similar to the risk factors of stroke and heart disease. So if we reduce our risk factors for heart disease and stroke, we actually reduce our risk factors of vascular dementia, which is really positive. People tend to have a more stepped approach, so they might start to have issues with problem solving and organising, things like that, but they might stabilise for a while and then kind of have a step down approach to their decline, plateau again, and then move along and drop down. And that can be weeks, months, days. It varies from individual to individual. And of course, if they have both of those conditions, you'll start to see sort of a slow stepped or a more rapid change as the sort of more insidious decline of Alzheimer's disease runs in the background. Dementia with Lewy bodies disease is actually really underdiagnosed, we believe, because the symptoms are very, very different often. It could be that people have delusional experience, hallucinations. Actually, their memory might not be incredibly affected particularly, but there's also a lot of physical factors associated with Lewy body disease and Lewy body dementia. So people might have problems with continence, with movement, with sleep. Patients with Lewy body often are prone to postural drop, for example. So there's lots of other things going on in the background, and often people are diagnosed with depression or anxiety in the first instance, as opposed to people understanding that it's dementia with Lewy body. So people can wait a long time for an appropriate diagnosis. Frontotemporal lobe, again, is often more prevalent in younger people, so there's people under 65, because it's important to remember that dementia is not just a disease of older age, but younger people are affected. There's in excess of 45,000 people living in the UK who are under 65 with dementia. So, it's really important to recognise that. And with frontal lobe dementia, there's often changes to personality and behaviour. So someone who might have been quite calm might suddenly become very agitated. Someone might become quite callous and unfeeling. Their risk might change, risk factors might change. And again, you can understand, because of those sorts of changes, people might think it's stress or relationship issues. And again, it can take a long time to get a diagnosis. So it's really important to note those kind of subtle differences in the way that dementia presents itself, because obviously that will impact on not only the progression but the symptoms that person has as the disease progresses. So we're going to talk a bit more about how that impacts on the higher risks as we go through, and I'll come back and highlight some of those other areas along with colleagues as this session progresses. Next slide, please. I think that's over to Carol.
Zena, could you just pull your mic away slightly? We're getting quite a bit of feedback from your mic.
Yeah, sure. How's that? Is that better?
That's better. Thank you.
No worries.
So thank you, Zena. That's a really good and helpful background as to the different types of dementia. So this session today, we're just wondering, why are we specifically looking at dementia as a risk factor for pressure ulcers? And as Zena's mentioned already, people living with advanced dementia have a significantly higher prevalence for pressure ulcers compared to those who've got the same physical and comorbidities but don't have dementia. And this is due to a number of factors. Dementia brings about physiological, psychological, and social changes to a person's health and well-being. As we're going through today's presentation, we're going to explain in more detail what those impacts are and how we can support prevention. And just like we've done with the other webinars, we're going to frame the session around the asking model. Next slide, please, Emma. So what is the asking model? Well, prevention of pressure ulcers for all our patient groups has to be a holistic approach. And particularly for those with dementia, we need to consider and manage the key factors that increase the risk of pressure ulcers occurring. And it's recommended that we use a care pathway or a model to ensure that we don't miss anything. NHS Improvement brought a number of different models together in 2018 to create the asking model. Now, originally, this was created as an education module to make sure curriculum covered all of the aspects, but actually it works really well as a care plan. And in fact, NHS England are now advocating this as a national care plan format and rolling out more information this year. So asking stands for assessment of risk, skin inspection, surface, including devices, keep moving, incontinence, nutrition and hydration, and giving information. Next slide, please. So we're going to start with the first part of the model, which is A, the assessment of risk. Assessing our patients is the most important first step in preventing pressure ulcers and other complications. A risk assessment is going to help us to identify which patients are most at risk and who we should be focusing our interventions on. Next slide, please, Emma. So in people with dementia, a holistic assessment is especially important, as it's going to enable that high quality care focused on their individual needs. We need to take into consideration the overall health of the person. Are they living well with dementia, or are they experiencing a period of physical illness or other chronic conditions that are going to increase their risks? How are they physically? Can they mobilise independently, or do they need prompting or assistance to move? Can they get to the toilet and keep themselves clean? Do they eat and drink well? And what are their psychological needs? Are they distressed by their condition, or maybe embarrassed to ask for help? And socially, do they have a good network of people around them to support and remind them to move and things? Assessment for this group of patients will include not only the pressure ulcer risk assessment, but also we need to look at pain assessment, falls and frailty to get that holistic picture. Next slide, please. So risk assessments help us to get an earlier detection of individuals at risk and those who have already got pressure ulcers. The NICE guidelines state that a risk assessment should be undertaken as early as possible when a person accesses healthcare. They recommend this should happen within 6 hours of being admitted to a hospital or care environment, or at the first visit in the community. They advise that a formal tool should be used alongside clinical judgment. But what's the difference between that formal tool and clinical judgment? Formal risk assessment tools have the advantage that they're validated, repeatable, and reliable. They give clear prescriptive guidelines and they're easy to audit. However, sometimes they're not personalised to individual patients' needs, and health professionals can become really reliant on the score to prescribe care rather than using their clinical judgment and those holistic skills. So clinical judgment then requires a background and knowledge about your patient, experience, just that good eye looking at what those risk factors might be. How well is your person moving? What struggles are they having? And it's sometimes called the gut instinct. It's just that thing that as carers or nurses, we just know when somebody's at risk. But that can be really challenging for those who are new into healthcare. So a good pressure ulcer risk assessment should combine the use of the formal tools and the clinical judgment skills. Next slide, please, Emma. So in patients with dementia, a holistic assessment is especially important as it will enable high quality care focused on individual needs. We need to take into consideration their overall health of the person. Are they living well with dementia? Or are they, I've just done that bit, sorry, I'm repeating myself. Looking at a page I've already read. Alongside our pressure ulcer risk assessment, we need to look at the pain, the frailty, and the other risks of falls. Pain is recognised as an early indicator of pressure ulceration and often felt before damage is seen. Pain assessments can be quite a challenge for those with dementia. Their perception of pain or the way they express pain might be different. Pain is often poorly managed in advanced dementia as don't necessarily recognise those non-verbal signs. So we need to remember that somebody with dementia might have multiple conditions and they might not be able to express verbally that they're in pain or what type of pain they're having or where it is. So looking for those non-verbal signs such as agitation, distress, social withdrawal or resistive behaviours, or maybe even just rubbing an area that's feeling a bit sore or drawing up at their knees might be a good indicator that somebody's in pain. And we can use those pain assessment tools, you know, the ones with the smiley faces or sad faces or other things that might help to indicate whether somebody's in discomfort. Next slide, please. So frailty is also a really good way for us to identify if somebody's at risk. It's defined as a state high vulnerability to adverse health outcomes, and widely reported that frailty is associated with cognitive impairments and shares many of the risk factors and clinical features that we see in our pressure ulcer risk assessment tools. The most widely used clinical frailty score is used, scores people from very fit as number 1 up to terminally ill at 9. And dementia is specifically included in that ranking from mild, moderate or severe dementia, aligning with the mild, moderate and severe frailty. Someone who is very fit, well or managing well scores between 1 and 3, and they're generally active and mobile and may have conditions that are quite well managed. Whereas someone who falls into the vulnerable or mildly frail will be needing some assistance with their activity and mobility. And somebody who's moderately or severely frail is going to need more assistance and might be quite dependent on others to help them move with their personal care. And then finally, somebody who's very severely frail or terminally ill means they're completely dependent and not likely to recover from illness. So this gives us another way of identifying those risk factors. If we're not using a specific pressure ulcer risk assessment tool, the frailty tools can be quite useful as well. Next slide, please. So alongside looking at the immobility and the risk of pressure ulcers in people with dementia, it's important to recognise that they're also at really high risk of falls. And this can subsequently lead to prolonged periods on the floor or injuries which compromise their skin condition. And some symptoms can make people more at risk of falls, and some health conditions go alongside that. Next slide, please, Emma. So people who are at most risk of falling are those that might experience problems with their mobility, their balance or muscle weakness. They might have difficulties with their memory or finding their way around. And we were talking the other day with Zena and pointing out that we often see signs for rooms or toilets on the outside, but not on the inside of a room. So if someone who becomes very disorientated quickly can't find their way out of a room, that might lead them to trip or knock into something. They may have difficulties processing what they see and reacting to different situations. They might be taking medications that make them drowsy or dizzy or even lower their blood pressure. They might not recognise that as something that's going to put them at risk. And they might find it difficult to communicate as well. And the other thing that I've seen in practice is that a lot of people with dementia have altered sensation to their feet, and that often causes them to shuffle or change how they move, or possibly wear the wrong shoes or the wrong fitting shoes as they try to mobilise. I've even seen no shoes, which can put somebody at risk of falling or causing a problem. And if somebody does fall and they're laying for a long time, the risk to pressure damage is huge, and it's often delayed as well. So we don't often see it immediately. It's sometime after they've been picked up and got somewhere safe. Next slide, please. So our next bit of our asking model is our skin inspection and skin care. And we need to be thinking about this alongside our risk assessments. We need to check the skin for signs of breakdown or changes in colour or feeling so that we can identify the early indicators of pressure damage as soon as possible. Next slide, please. So to assess the skin, it's always good to recap the anatomy and how it changes as we age. As we age, the skin becomes wrinkled and less elastic. The collagen changes as our skin degenerative changes happen, and the skin becomes much more dry. Our dermal epidermal junction flattens, so the skin's less stretchy and at much higher risk of trauma or lacerations. About moving and handling and sliding, also risking the skin. The sebaceous and sweat glands become less active, so you see a lot more dry skin conditions as the hormones change as we get older. And our skin is much more susceptible to sun and environmental exposures. And as I've mentioned before, dementia can cause neuropathy in those nerve endings. So the messages to the brain that the skin is getting sore or a problem can cause a lot of problems as well, because they don't know that they need to move or change something. Next slide, please. So our epidermal barrier is a highly specialised and adaptable to environmental conditions. It provides a physical barrier, but it also triggers the immunoresponse against pathogens and quickly repairs breaches when it's healthy. In healthy skin, the stratum corneum is impenetrable to irritants and allergens, and water loss is minimised. But when the skin becomes dehydrated or as it's aging, that stratum corneum shrinks and starts to crack and starts to allow penetration of those exterior irritants. And that in turn triggers inflammation, irritation, itching, swelling, scratching, and discomfort. So that's already going to be putting skin at risk before we even get to pressure as well. And the whole structure becomes weaker and more susceptible to damage. It's thought in the UK, about 54% of the UK experience a skin condition in any 12-month period, but only about 14% of people will seek medical advice from a nurse or a doctor. Most people will try and manage with products bought over the counter. Next slide, please. So when we're doing our skin assessment, we need to include our dermatological, what is the skin condition? Our psychological, is there anything impacting the skin condition? And social, is there anything in the environment or medical conditions impacting on the skin health? As clinicians, we need to use all of our senses to gather that information. So we use our sight, physically looking for discoloration. Is there skin breakdown? Is there moisture or dryness? Are there equipment or devices in contact with the skin that might be pressing and causing pressure that might need moving? We need to use our hearing, listen to our patients. What do they tell us? Are they telling us somewhere is sore or uncomfortable? Have they got pain over a particular area? Or are they telling us a story about a previous skin breakdown or problems that they've had in the past? And smell can be really useful when somebody can't tell us themselves what's going on. An odour might indicate infection or fungal growth, but it also might give us an indication that someone's struggling with their personal hygiene or incontinence. They may have been a bit embarrassed or not able to tell us what's going on. And then touch. What does the skin feel like? Is there bogginess or firmness? Is it hotter in one area than another? Is there any edema or swelling or heat? Remember, early inspection helps us with early identification of problems. Skin inspections need to be frequent, not just a one-off, and every opportunity. So if we're helping somebody washing, dressing, toileting, repositioning, these are all really good times to be looking at the skin and involving the patients and residents and their carers as well, so they know what to look for and feel, or know how it might feel if their skin's starting to get a problem. Next slide, please. I think I'm handing over to you, Anita.
Thanks, Carol. So yes, let's then have a look at the next S, which is for surface selection and use. And I'm going to extend this a little bit into equipment as well. So next slide, please, Emma. So I suppose it's really important to recognise that when we are putting equipment in place or we're assessing for equipment, that we try and take a person-centred approach to doing it. I think often equipment, we prescribe equipment, don't we? So we often use our risk assessments, and we may well just use our risk assessment, and we may well not think about kind of the actual implications of that equipment being in place. And I don't necessarily mean the clinical implications, because I think that's always very much in the forefront of our mind, but we may be thinking purely about clinical effectiveness than actually how it might impact on patients themselves. So we really need to think about, are we listening to our patients? Are we listening to their families? Is this piece of equipment that we're looking to implement actually really necessary? Because if it isn't, then it may well impact on the patient's home environment, or even in terms of their care setting. It might disrupt something that has become very familiar, or disrupt a routine within that familiar surrounding. So we need to think about, yes, is something best clinically, but also what is best for the patient. And it's about looking at how we work around this. So next slide, please, Emma. I'm actually going to talk you through a case study. Now, this case study was from a colleague here at OSCA. And within her community nursing team, she looked after a 92-year-old gentleman who was living alone, deemed to have capacity. So no, this patient didn't actually have dementia, but this can be very much related to this scenario. So this patient was actually a survivor of the Second World War, as you can gather from the picture that we're showing currently. And he was a Dunkirk survivor. So for those of you who don't know, Dunkirk was a part of the Second World War. We sent a lot of soldiers over to France. Unfortunately, that mission didn't really go according to plan, and we had to rescue these soldiers pretty quickly. So if we can keep that in mind as we're going through this, this case study. So this gentleman had a kyphosis, so he had a curvature of the spine, and due to that anatomy, he started to develop pressure ulcers down the spine. So the nurses decided, well, what we should probably do is advise him to go to bed every afternoon to offload that area. And so they advised this, they put a few things in place to encourage, they tried some V pillows, and they put other specialist equipment in. But actually they found that this patient wasn't going to bed, and actually the spine was getting worse. So the areas of pressure damage was getting worse. And actually his attitude was, well, I'm 92, and actually if I want to sit in the chair, I don't want to go to bed. So I've had a good life, and if I end up with pressure damage, then, so be it. But unfortunately, the spine was deteriorating further. So because this gentleman wasn't going to go to bed, they decided, well, we'll get an air cushion then. So they put an air cushion, and it was one of those air cushions that goes under the bottom, but also goes up the back of the chair as well. So they put that in place and thought, well, at least if they've got that, then he's going to be getting a level of offloading or pressure redistribution. And so actually that we should start to see an improvement. And so it went on for a little bit of a time, and actually there was no improvement that was being noticed. And actually, if anything, what they were finding was that this gentleman was becoming very angry, very upset. So his behaviour was changing, and actually that self-neglect part was actually getting worse. And so they didn't quite understand why. And it was a chance meeting with a neighbour. And this neighbour used to go in to see this gentleman twice a day to empty his commode for him. And so this chance meeting, this neighbour said to the nurse, oh, well, he doesn't like the cushion. And she sort of asked why. And he said, well, it's because he's a Dunkirklander. And so she didn't know what that meant. So she asked a few more questions. And actually, what happened to this gentleman was that he was rescued from Dunkirk, and he was rescued in a small tugboat. And there was lots of different boats and size boats and military boats and civilian boats that went over to Dunkirk to take part in the rescue. And so he managed to get on a very small tugboat. And as they were going away from the beaches, there was lots of bombing going on around them, so lots of shells going off. And a shell actually landed right next to the tugboat, and that meant the tugboat capsized. And so this gentleman apparently hung on for dear life and continued to cling on to this boat. And actually what happened as a result of that was this gentle rocking up and down. And unfortunately, because they placed this air cushion underneath him, that was also recreating this gentle rocking up and down. And so this behaviour change was coming from the fact that there may have been an element of post-traumatic stress disorder, and actually it was instigating really bad and painful memories for him. And so it meant that the nursing team had to reflect on what they'd implemented, what they put in place, because yes, clinically, it was probably the right thing, something that was going to give clinical benefit. But actually, from an element of I suppose, holistic assessment, but also from the patient's point of view and how tolerable something was and how comfortable something was, it wasn't the right thing. So I suppose it really does highlight the fact that we do need to look at things much more holistically. And actually, if they'd spoken to the patient, spoken to family, potential lay carers, friends, anybody like that, actually, we may have got a better, more rounded picture and been able to implement the right type of equipment. And actually, that can be very relatable to dementia, because it could just be the texture of a piece of equipment, the colour of a piece of equipment. And like I said, that disruption to routine, that disruption to their environment that suddenly makes something look very unfamiliar, that might mean that we think that they're not being compliant or concordant with the care that we're providing. But actually, it's much bigger than that. And we really need to be able to reflect on what we're doing and delve deep into what is going to be most appropriate. Next slide, please, Emma. So when we're thinking about equipment, or we're thinking about support surfaces, so those mattresses and cushions, as we've just been discussing, it really is key to take that holistic approach. So use your risk assessment, absolutely, but use, like Carol was saying, that clinical judgment, that little niggle in the back of your mind that makes you think, do you know what? This risk assessment is saying this, but actually I think this. And that questioning, that deep dive into your assessment will hopefully give you that extra sort of knowledge to give you that niggle, that clinical judgment that's going to give you a much more rounded approach to your assessment. And so people with dementia may well come out as high risk, and that often leads us to think, okay, if someone's coming out as high risk, then actually we probably should put them on an air mattress. But I would just hazard a stop at that point and really think about what that air mattress might be like for somebody with dementia. And we often question what is best. Is an active surface, so an air mattress, or a reactive surface, something that is static, going to be better? So air mattresses can be brilliant for those high-risk individuals, absolutely, because there is going to be an element of offloading. But we often have to think about how tolerable that's going to be for somebody. And so if somebody's got dementia, it actually may make somebody feel a bit more disorientated. It may make somebody immobile because actually they were able to move on a mattress and now suddenly it's moving and they're feeling a bit disorientated. So actually, I'm just going to stay put. And it might change behaviour, as we saw a moment ago in that case study. So we really need to consider lots of different things when we're looking at support surfaces, and that could be mattresses or cushions. And actually, if you make a decision that actually a reactive, a static surface is better at that point, then if you've got your clinical rationale for that, that's absolutely fine. And remember, support surfaces are just part of the whole asking model. And actually, it's just a part of the jigsaw puzzle. So actually, we can put a certain piece of equipment in place, and then we just look at the rest of the care plan and tweak that accordingly. So certain things to consider might be somebody's anatomy. Again, as we saw in that case study, everybody's different. So not all equipment will suit everybody. And we also need to think about the positioning of our patients as well. How easy is it for either them to reposition themselves or for us to reposition them if they are in bed or if they're sat out on a cushion? But also we need to think about things that happen within dementia, like muscle wasting, contractures, spasticity. All of those things can lead to difficulty in repositioning. They can lead to peak pressures over bony prominences. And so we need to think about all of these things. Contractures, again, you know, if somebody is in a fixed position, we may need to think about what surface we use, because actually one that's moving may not be suitable. And so we need to think about, so again, something a bit more reactive. And I said before, mobility, you know, we really need to think how are we encouraging mobility with the surfaces that we're choosing? And if we aren't encouraging mobility and we're actually immobilizing somebody, then we need to be very mindful of that and actually think about how we can use equipment to better aid mobility. So there's things about, are they able to get on and off of a mattress easily? Are they able to move around if they're sat on a certain cushion? And then we also need to think about things like noise and the lights on pumps, you know, things that could be distracting, again, disorientating. We know that sleep is really important for dementia, and actually if that is being disturbed in some way because of the noise of a pump or the lights on the pump that are distracting, then obviously, I mean, you know, people will suffer from lack of sleep aside from having dementia, but actually that can really impact on the symptoms of dementia as well. And for those individuals who may not be able to mobilise and might even become distressed if we try to reposition somebody, we could use lateral tilting devices. And you can see that one there on the screen, our Series 5 from Oscar. But lateral tilts will vary. So some tilting mechanisms will lift somebody up. And actually, that isn't always ideal because someone has got to have a really strong core, and that can be quite disorientating. And we've got to try and obviously prevent lateral travel at that point. So we might need to think about something that is more gentle, something that actually tilts into and dips into the mattress rather than lifting up and out. And as you can see on the screen there, the Series 5 from Oscar there, that lateral tilting mattress is something that will tilt somebody gently into the surface rather than lifting somebody up. So it's about choosing the piece of equipment that's most appropriate. And then lastly, as you saw in that case study, past experiences is really important. And equipment, for whatever reason, may start to bring up either really good past experiences, but also things that have been a little bit negative, or just general feelings from a past experience that can then obviously lead to changes in behaviour, as we saw in the case study. So it's really important to really think about what you're using and why, and what's going to be most tolerable, most comfortable for the patient. Next slide, please.
Anita, before we carry on, as anticipated, we've got lots of questions coming in, but this one really is of the here and now. Somebody has asked, what is the difference between an active and reactive surface?
So an active surface is one really with a pump, is one that's moving. So an active surface is essentially an air mattress. So anything that is moving up and down under the patient to relieve pressure, or the tilting surfaces that you get as well. So anything with a pump essentially is active. Reactive is basically static, and you can get numerous different types of reactive surfaces, but they basically react to patient positioning. So as and when you change somebody's position, the mattress will conform again to that part of the body, and some different types of foams and static air surfaces will do things slightly differently. Some will just immerse and envelop somebody and react to repositioning. Some are able to keep a constant low pressure as well. So obviously there are different types of surfaces in that respect, but the main difference, like I said, is the active has a pump, the reactive is static. So that, in a way, kind of nicely moves us on to keep moving, which is the next part of the Askin model. So this is really about how often we're encouraging movement, but also how often we may be repositioning somebody as well. So next slide, please, Emma. So I just wanted to recap really sort of general guidance over keep moving. So according to NICE and the EPUAP, we should be repositioning our patients unless otherwise contraindicated. And that should be on an individualised schedule. So it shouldn't be that we just move everybody every 2 hours. It should be very much individual based on your assessment and your clinical judgment. And again, think about somebody's anatomy, because obviously there may be people that need to be moved more often in a certain position because of the way their anatomy is than in another. So it very much is holistic, very much looking at individualised regimes. So we can also use functions of profiling beds to optimise positions. So we can raise the head, obviously not above 30 degrees, but we can raise the head of a profiling bed. We can also raise the knee break as well to stop someone sliding down the bed, and encourage good positioning and good postural positioning as well. And if somebody is able to reposition themselves, then we need to be encouraging that often. Now, I know it says there that, every 15 to 30 minutes, and I can see all the eyes rolling and the kind of sighs as I'm talking. I know that's not easy, but it's encouraging it as much as possible and recognising those times when we actually do reposition and we probably don't even realise we're doing it. So if we are helping somebody to the toilet, if we are, rolling somebody over during personal care, all of those moments whereby we're probably doing it very informally, they're all moments of repositioning. So just, I suppose, think about how often you're doing that informally as well. But if we can encourage people to move, then we may think about asking them to kind of tilt from side to side in their chair. Are they able to stand themselves up, sit themselves down, and just stand them up for a couple of minutes? If they're able to mobilise with the aid of walking aids, then are we encouraging that as much as possible? And then in terms of dementia as well, are we helping to support that? So if they are able to mobilise, are we going with them? Are we supporting them in that respect as well? We also need to remember things like zips, buttons, seams, wrinkles, tight clothing, anything that can compress against the skin and cause a problem. And that's the same with slings as well. I know sometimes we're very much in, we know we need to remove slings, but sometimes they do obviously stay under people. And so we need to think about, if we can't remove a sling for whatever reason, looking at those seams of that sling, are they digging in anywhere? Can we negate that in some way? Next slide, please, Emma.
Anita, another question again for the here and now. What's your view on repositioning frequency at night with those who have a pressure ulcer?
Going to be very individualised, and guys, feel free to join in on this one as well. It is very individualised, and ultimately, what we don't want to be doing is disturbing sleep at the same time. So there may be a time where clinically we really do need to reposition somebody a little bit more often overnight. But generally speaking, if we have all of the right elements of those care plans in place, we're assessing the skin regularly, we are making sure they're on the right type of support surface, it may be that we can increase times in between repositioning. That said, we may also need the use of like a lateral tilting device that may be able to support that repositioning overnight, so we're not actually physically going in and disturbing them. But it is going to be repositioning. I would love to wave this magic wand to say this is exactly what you do. It is a balance sometimes of risk, isn't it, between what clinically we need to be doing and what is better and more tolerable for the patient. And guys, if anyone else on the panel wants to chip in with anything, then please feel free. But hopefully that's answered your question.
Thanks, Anita.
You're welcome. So next slide, please, Emma. So from a dementia point of view, in terms of movement and keeping moving, that's going to vary depending on what stage of somebody is with their dementia. And it's like I say, it will vary from person to person. So if anybody's got partial mobility, then we really should be encouraging movement. And then it's about thinking, I suppose, of almost novel ways in which to do that. So obviously, if someone has dementia, they may be very wary of their surroundings and may not understand where it is they need to go or what they're supposed to be doing. So we know, therefore, that they may well just stay safe in their chair or in bed, because actually that's the safest place to be. But we really should be encouraging movement and supporting them to do that. So we could use things like visual cues, so just simple symbols, pictures, not necessarily instructions, because that might lead to frustration probably from both parties if you're constantly having to instruct. But if you are able to use visual cues, like I say, pictures, phrases, anything that can help remind somebody to move and encourage independence as well, then visual cues may work. Alarms may be something that you could use as well. Again, this is going to be very much down to an individual and your assessment of what is going to work best. But we mustn't also forget, if we're in care homes, we've got activities coordinators, and actually they do great work in terms of helping movement and encouraging movement. Any activity where there is some sort of movement will help with pressure redistribution of some sort. And that could be activities that might relate to, I don't know, to somebody's previous job. It could be just general exercise activities. We might also include some reminiscence in there as well to kind of engage the residents and the patients in actually taking part in the activities. So, you know, there are things that we can do. Obviously, we do need to think about safety, and obviously we will get residents that will wander and they may shuffle their feet. So we need to think about blisters and correct fitting footwear, but checking feet regularly, checking heels regularly as well. Next slide, please, Emma. So, yeah, this is just reiterating that really, isn't it? But it is really, really important from a pressure point of view to be looking at the feet, looking at those heels and checking them regularly. And this, yes, is general advice. But if we have got residents that are wandering, if we have got ill-fitting footwear, if we have got things that are going to cause any sort of blisters, extra pressure, so think about those socks, hosiery, bandages, dressings, which may be present, we need to be making sure that we are checking those areas regularly. And as you can see on the picture there is a nice little picture of a compact mirror that honestly is the best thing to be using when you're looking at heels, so that you're not having to kind of contort yourself to get underneath. So yeah, I would encourage anybody watching and listening today to, if they are looking at heels, to have a little compact mirror.
We have another question actually that fits really nicely here as well. Our physio staff would suggest no shoes with a non-slip sock is better for a number of patients. It enables more sensory feedback. This is one for Carol and possibly Anita. Carol, you are of a different opinion. Can you explain, please?
Yeah, that's an interesting one. I think it goes back to that holistic assessment and what's best for that individual patient. So I would say that a good fitted pair of shoes or slippers that are the correct size and shape are always going to give better support for the foot for mobilizing. But the anti-slip socks are going to be softer. They might, as the physios have suggested, give better sensory feedback to what the person's walking on. But I think it's very dependent as well on the floor surface. So whether it's carpet or lino, depending on where that person is, because the slip socks can, they can stick to carpet and slip round, whereas a pair of shoes or slippers are going to be much more secure. So I think, yeah, both have got their place, but it's got to be based on that assessment.
Can I just jump in as well and just add to that? Because if somebody has a sensory impairment and they also have risk factors such as neuropathy from diabetes or other conditions, they're at a very high risk of getting plantar pressure ulcers. And I've had a case of a person with dementia in a care home who walked a lot. They walked a lot at night and developed plantar pressure ulcers. So obviously without correct footwear, then that is an issue. So it's that individualized risk, and you have to balance that really.
Thanks, ladies.
And I think I'm handing over to Zena.
Hopefully you're not getting as much feedback this time. So we're now going to move on to incontinence assessment and care, which is something that I feel really strongly about in relationship to dementia, because often continence or incontinence is seen as a symptom of dementia, and that's not the case. People with dementia have multiple comorbid conditions often. In fact, 90% of people with dementia have at least one other comorbid condition. And they're often things like COPD, diabetes, they might have mobility issues, all of those things which exacerbate their likelihood of having problems with continence. So it's really important that we promote continence in people living with dementia. Next slide, please. So Obviously, we know that there are lots of factors associated with incontinence and damage to the skin. So that moisture associated skin damage is not directly, of course, but obviously it weakens the skin structures. It makes it far more likely that there's going to be evidence of rubbing and shearing to the skin. So it does put extra pressure on, or it increases the risk of pressure in the skin. So we know that there's almost a pad culture in some environments. There's been research that talks about the fact that when people with dementia go into acute hospitals, for example, continence isn't promoted. They're automatically popped into incontinence pads, because it might be that they are not able to communicate their need to go to the toilet, or the environment may be such that they don't feel able to mobilize to the toilet, and so that the incontinence pads is a means of containing that within the hospital environment. But we also know that as people progress to the more advanced stages of dementia, they are more likely to be incontinent as a result of those issues, such as that inability to communicate and mobilise independently, or recognise when they need to proactively go to the toilet. We again get those situations where people, because of those concerns, don't drink enough, for example, because actually they think if they don't drink, then they won't have to go up to the toilet so much, or they won't be as incontinent. So again, that increasing enzyme in the skin is causing further damage. So there's all kind of these factors that brought together, really cause not only discomfort to the individual, but that increased risk. So one of the things we need to think about is looking at why someone might be incontinent. So ensuring that they have a proper continence assessment, not just assuming that because they have dementia, they're going to be incontinent. It's about looking at all those other factors that might be relevant to that person as any other person. So looking for perhaps stress incontinence or an overactive bladder, looking at all those elements. And if not, thinking about those functional elements of incontinence. Environment is really, really important in terms of people feeling safe and confident in getting to the toilet, for example. And Carol touched on things like signage earlier, and different colours to be able to distinguish where things are. So toilet signs, for example, with a picture of the toilet, so something familiar that enables that person to recognise where the toilet is. And that can be done in the home environment as in residential care, as people become less familiar with their environments. It might even be things like flooring. So shiny floors, for example, might look like water to someone who's got sensory perception issues with dementia. So again, they might not get up because they're feared that they're stepping into water, or a big rug, for example, might look like a hole. So, it may prevent them from getting up and going to the toilet. But going back to pain, if people's pain is better addressed as well, it may be that they're able to mobilise more effectively and get to the toilet. So it's really important that we do these multifaceted assessments, because it's really easy to sometimes look at one problem in isolation, whether that be continence, falls, dementia itself, or skin damage. But actually, as we start to pull all those elements together, we get a much better understanding of what might be going on for that person, and we can actually reduce the risk of so many other things as well. Next slide, please. So again,
sorry, again, another really, really appropriate question here. You might be able to offer some guidance on. They've said, I always find that if a patient does not have their own clothes whilst inpatient, there is not another option for underwear other than incontinence pads, which will make the patient and other professionals assume incontinence. Any thoughts?
I have to say I haven't seen that as familiar. I think where I've worked in the past, they've had the sort of the paper underwear that you often use for theatre and things like that. But I think absolutely promoting family to bring in undergarments. I think because it's almost, we get into that stereotype of the sick role, don't we, where we expect patients to be in pyjamas or nightwear, and there's this assumption that they don't wear underwear for whatever reason, or people aren't washing underwear as often as they like. But you're absolutely right. And I think, again, when people go into hospital, it's very rarely pull-up pants that they're often. It's often net knickers and pads, which again are quite cumbersome if you're not used to them. They can feel quite alien. So those in themselves can feel really difficult. So I think absolutely, for me, again, it's about that individual assessment, even when we're looking at people who get transitioned into pads too soon, but even when people do need some support with pads, is actually identifying what's the right one for them, not just looking at the volume of fluid that needs to be collected, but actually what is going to be more manageable for them in terms of maintaining their dignity and promoting continence rather than managing the incontinence. But I think that's a really valid point. And I think there are a lot of people, particularly females, as they get older, who might use a very discreet pad in a pair of underwear, which makes them feel more comfortable, and, you know, that just in case they have some leakage. And again, as you say, if they're not wearing underwear in hospital, that becomes an issue in itself as well. So I think, yeah, it is about saying, well, what would this person normally, what's normal for this individual, rather than us kind of seeing the diagnosis and us kind of behaving in a certain way. Because like we said, dementia is so many different things. And once if you've met one person with dementia, you've only met one person with dementia, because their needs and the way that they promote their well-being is going to be very, very different. And kind of going on from that is, you know, about promoting that continence is to support people with toileting regime. So it may be, again, they can't verbalize that they want to go to the toilet. So it may be that you have to encourage and prompt them and encourage them to go to the toilet, or show them where the toilet is. You know, do work with continence advisors and advocate for the people you look after. And go back to Carol said about the toilet signs on both sides. We're seeing a lot more toilet signs where you can guide people in, but not so much when you guide people out. And contrasting colour is really important, because often people's eyesight or their perceptionary issues are affected. And when you go into a lot of particularly hospital or residential care home toilets and bathrooms, they're often very pale colours, greys, whites, beiges. So it's really difficult for a person to go into a very grey room and identify a white toilet. So, for example, a coloured toilet seat, which is quite in a primary colour, such as red or blue or even black, just something that contrasts with the main environment, will be visible and able to see that. And that will promote and support continence as well. But equally, encouraging people to be able to leave that room safely and not feel trapped in a contained space by having signage that shows them how to get out as well. If someone does need continence pads, it's not just about promoting, as I said, capture of fluid or feces, but it's also thinking about how does that person and perhaps their family carer manage best. And certainly I've had cases where perhaps male partners are looking after their wives, and actually the pull-up pants are far easier for them to manage, because the lady herself might be able to pull them up without any support, which means they can maintain their independence longer. But also from a practical point of view, actually trying to negotiate a pad and pants can be really, really difficult for some people if they're providing care to their spouse or a loved one. And they should be shaped more like underwear, because it's more recognizable. It doesn't feel alien. And I've had lots of patients with dementia, when they've had the pad and pants, you know, they'll pull the pads out, and actually that becomes even more uncomfortable, because they've got the net knickers straight on the skin, which can be quite hot and sweaty and very uncomfortable. And equally, it doesn't manage any loss. So it's really, really important. And again, promoting that hydration and reducing that risk of that level of ammonia in the urine that could kind of cause even more skin damage. But of course, if someone is incontinent, is about appropriate cleaning, and, you know, not using abrasive wipes and things, but actually using good light pH low moisturizers and creams and things like that don't irritate the skin. Emollient creams when possible, and making sure it's dried. And I think that's often a real difficulty. So it's about being really sensitive to that person's needs as well, not rushing them, encouraging them to do as much as they possibly can for themselves. So promoting that independence, because if you start to take over, that, you know, that only impacts on their dignity, but also their ability to maintain their personal care in the best way that they possibly can. Obviously, the old adage is about not using talcum powders and and oil-based creams applied to people with dementia as with others, and thinking about the barrier creams and what's appropriate for that individual. And also it's about the application of those and thinking about talking the person through what you're doing. A spray, for example, may be an absolutely appropriate product, but if you spray it without actually telling the person what you're going to do, that can be quite frightening. So you have to, communicate with the person at all times about what you're doing and why you're doing it, because actually what you want to do is encourage them to be compliant and supportive of the care and engaged in it, rather than see that as something that's invasive and really uncomfortable. And now I'm going to hand over to Alison.
There's another question, actually. Sorry.
No, not at all.
They're coming in thick and fast. It seems like we've sparked some lots of questions here. It can be very difficult to manage incontinency needs for those unable to use a toilet, commode, urinal, etc., when they are only allocated a maximum of 4 incontinence pads per 24 hours, especially if they are confused. Also, the pads supplied are not at all dignified or adequate for purpose. Again, any thoughts, any advice?
I can completely agree. I think there is a real problem in terms of when people are assessed, what products are actually supplied to them. Obviously, we've got a lot of people who are self-funding and actually don't meet the threshold often for products. So again, it's about supporting them if they're going to purchase their own products, to advise them on what's best for them. And I often come across a lot of families who say, we don't mind topping up the supplies if we think that that's going to promote dignity and be comfortable for the person that we care for, or our family member. We're quite happy to pay for it, but some people don't know that option's available. For me, I think there is a real conversation to be had at a very, very high level in this country about that, promoting continence in a way that's meaningful, and actually looking away from how much it costs per pad to thinking about what it costs that individual, both then and longitudinally if their continence isn't managed. Because we know, for example, that a lot of people who are family carers have to give up caring because continence becomes an issue at home. So it's a very short-sighted approach, and I don't think I have the answers, but I completely agree with you that actually a lot of the assessments are not person-centred, they're volume-centred, and that's not what good person-centred care should look like. So I share your frustrations is probably what I would say to that.
Thanks, Zena. Are we moving on to Alison?
We are. Thanks, Emma. Hello, everybody. It's the next slide on from that, I believe. Is
that right?
No, I'm nutrition.
There
we are.
There we go.
We're moving swiftly through the asking. I was interested in that because when we did the asking with NHSI, Carol and I were part of that working group, and my section was the incontinence. So a great job there by Zena. It's really important to me, is that one. But the nutrition and hydration assessment and support, if we'll just move on to the next slide, please, Emma. Now, if anybody's heard me talk about nutrition, relating to wound healing, and I know I've covered this section within some of our OSCO webinars before as well, I will always say, to me, I could argue it's probably the most important aspect, because this is how we are fueling the engines and all the workings of our bodies. And the risk of malnutrition increases as a condition of dementia does progress. So what is malnutrition? And I've just got a definition from the World Health Organization that says it refers to deficiencies, excesses or imbalances in a person's intake of energy and or nutrients. So energy obviously been related to particular food groups and what that does to our bodies. And also on the list of probable causes of malnutrition, cognitive impairment is on there too. So this is why it's important that we all complete, alongside our risk assessments, our malnutrition assessments. So we probably all on the call today perform the MUST assessments. There are others, and there is one actually which is specifically for aged people are very good for in care homes as well, but must is the one we usually use. And I'm not going into detail of that today, but I just want to say, because I always say this, when you are performing a must assessment, if I'm taking my weight today, I cannot then, when I'm performing my must calculations, I'm not comparing my weight today with my weight just 1 week ago, because that's going to tell me nothing. I need to look at my weight at least 12 weeks ago, or 12 weeks, you know, more than that, 3 months, 4 months, etc., because then that will calculate if there's been any percentage of weight loss. Now, I've just come back from a cruise, so I can tell you that there'll be no percentage weight loss. It will be increase, trust me. But but if the BAPEN website, if you're not unsure about that, what you're talking about, we need some training, go onto there and it's all on there. So due to the cognitive and mental impairments that we get from people living with dementia, and obviously that, you know, the knock on into physical disabilities, psychological factors, which may include, we've talked quite a lot about agitation, but that may be low mood and depression as well. You know, these can then have an effect on people that are struggling with eating and drinking. So, you know, we know that the nutrition is vital for skin health, and when somebody then has a wound. So if you think of somebody with a pressure ulcer, like a category 3 or, you know, a big category 4 pressure ulcer, and unfortunately we still do see those. And anecdotally, we are told over the last few years through lockdown, COVID, etc., and all the other issues that we've had an increase in, you know, severe category 3 and 4 pressure ulcers. So if you have one of these, you know, how do we overcome the challenges of that malnutrition and help people through their nutrition and hydration to help alongside their wound healing? I mean, malnutrition, Zena was talking at the beginning about the numbers of people with conditions of dementia. And we know malnutrition affects over 3 million people in the UK. And 1 in 10 of those is over 65, and that's from NHS England. And you can do a quick, simple test for if somebody's malnourished. You take the skin on the back of your hand and you just pinch it like that, and it's called a Turgor test. And if it bounces back, it's like a 1 second test, then we're okay. But if it stays kind of standing up proud, the skin, then likely somebody is malnourished. So we can do that alongside the must assessments. 29% of people who are admitted to hospital are malnourished, and those admitted with category 3 and 4 pressure ulcers are virtually all assessed as being malnourished as well. So something to think about. So those calorific demands of somebody with a wound, you know, really do increase. And as you know, we worked to the European Pressure Ulcer Advisory Panel guidance and recommendations and classification. And they advise that we should be having 30 to 35 calories per kilogram of weight for somebody who is at risk of a pressure ulcer, despite having a pressure ulcer. So if they've got one, that increases further. So that looks like, if you've got a pen, you could probably write this down. So somebody who is 10 stone or 65 kilo, therefore would need between 2,000 and 2,300 calories a day at risk, and more than that if they have a pressure ulcer. Now, take into account the factors of somebody having a condition of dementia, obviously maybe other comorbidities, and having the pressure ulcer itself. Is that really achievable? How do we do that? And it is quite a lot. And thinking about the types of food that we're asking somebody to intake. You know, fats supply a lot of energy, that's good, but saturated fats keeps the body in a state of inflammation. So we have to be thinking around terms of unsaturated fat for that calorie increase. So things like we can get from cheese, whole milk, cream, butter, olive oil, avocados, if you like those, nuts, seeds, and oily fish as well. Carbohydrates produce good energy for our leukocytes and macrophages, all that cellular process that goes on around when a wound heals. Also, carbs stimulate the blast growth, and also collagen, which creates that new skin structure. We've also got the micronutrients, so they're our vitamins and minerals, and just a few there. Vitamin B12, that will help in red blood cell formation. Vitamin C creates the collagen. Vitamin D increases the immune function and the bone growth. And we know as we get older, we can develop conditions as well, such as osteoporosis or, arthritic types of problems. And the density of the bones tend to reduce. Zinc as well for normal cell growth. So there's so many elements of nutrients, and protein, which is absolutely vital. And it's made up of 20 amino acids. And in the absence of adequate energy elsewhere in the diet, the body will start to break down the protein stores to use. And we need all that for the wound healing. So again, somebody who's 65 kilos will need 97.5 grams of protein a day minimum if they have a pressure ulcer. And that looks like 7 eggs, or it might be a 250 gram rump steak. It might be 2 big chicken breasts, 4 salmon fillets, or 24 avocados. Now, I like an avocado, but 24 in a day is pretty high. But what I'm saying is that's an amount of protein for this particular group of people that we're talking about. So how do we kind of overcome that? So Pete, think about the issues. So does somebody need help and support to eat or drink? I remember in hospitals at one time, they were introducing the red tray system, which identified somebody. So when their meals came, it came on a red tray if they needed help. There's nothing worse, is there? You might be there working somewhere and where people are, in 24-hour care, or you go to visit somebody's a relative and you see somebody, don't you, of, their food, their meals, their drinks are put on a tray table, and it's just left because they're not recognizing it, or they've no appetite to take that in, and they need that support with that decreased sense of thirst. So we have to encourage that. And as Zena said, that then can knock on to the pH of the urine, and that the enzymes in things like liquid feces. So thinking about the types of food that it might upset somebody's stomach, or, is their urine, too concentrated? That'll cause that burning sensation, that excoriation to the skin. What about the dentures? Have they been have they lost weight, malnourished, and the dentures are not fitting correctly? Can somebody chew? Dysphagia, so swallowing issues. Do we need to get speech and language assessment involved? Ongoing other assessments. And people with dementia may also experience that they're either eating very quickly, or they're asking a lot for food, often saying that they're hungry, and have these types of compulsive eating needs. And how do we manage that? The next slide, please. So interventions that we can do, oral supplements. So we follow the guidance on this, and the European Pressure Ulcer Advisory Panel says offer fortified food, high calorie, high protein, nutritional supplements between meals if the nutritional requirements are not being met by the dietary intake. So if we can't sustain what we've talked about, the amounts that somebody needs at risk or with a pressure ulcer, and it's all there in our guidance, NICE and the UPAP, then nutritional supplements we can get high protein ones can be considered. We do this, of course, alongside of our integrated working with our MDT teams, including our dietitians, our nutritionalists, our GPs, our tissue viability nurses like me and Carol, specialists like Zena. We do that all together to look at what is the best way and what is the best individualized care for that patient. It says on there about the assistance with eating and drinking, and do we need to adapt the types of cups? There's like the sipper cups, isn't there? If somebody has got swallowing problems, or to aid to hold different types of new utensils. Working with our occupational therapists and our physios, to have adaptations to that person's journey of their, through their day and their through their meal choices. On the supplements, NICE suggests as well that various nutritional strategies to improve. So all these different strategies should be used to improve the dietary intake, and the food fortification and nutritional supplements should be considered if there is a risk. So the environment, that somebody is in can really affect of their nutritional intake. And if somebody's in bed, if they've got the pressure ulcer, and then we kind of have gone that to reposition in bed, they're spending more time in the bed. We have to be careful of being too paternalistic, and also telling people that they have to go, right, you've got a pressure ulcer now, you go into bed and that's it, you're on bed rest. Because it's about quality of life. And if somebody is in bed, yes, the profiling beds can be put into chair positions, but if somebody may not, they may not think, well, we can eat because we're in bed, that's not our normal behavior, we're not used to that. So to have a seating plan or a mealtime seating plan with adequate pressure relieving equipment is a really good important aspect of that. Food preferences, what does somebody like? I know I was talking to somebody who worked in a care home, and when I did my pressure ulcer prevention lead roles with our teams, we also, when we did our training predominantly into care homes, we invited everybody, the chef, the maintenance man, everybody was in there, and we talked a lot about the food. And they were like saying that sometimes, because modern diets, things might be introduced. And some of the residents, they were used to had that reminiscence of food from childhood. If you at my dad's 83 and he would want sponge and custard, he'd want a trifle and things like that. And you can fortify these things, or, there's kind of like meat and 2 veg and mashed potato dinners and things, anything with chili and things like that, forget it. So, but we do, seriously have to think about, what do people associate in their past? It may be that they're not eating something because they just don't like it. So we can, involve family members as well who might be able to help us out with that. So that recognition, that nostalgia, the reminiscence therapy, does work a treat. Also thinking of people's culture and religion, which is really important, when we're preparing meals for somebody. And if somebody's in their own home as well, I've been predominantly community nursing for 20 plus years, and my nana had dementia, and my mum was her main carer, but she still remained in her little flat on her own where she lived. And I know many people working in community where that is the case, and they might have carers going in so many times a day, supplemented by family support. But are they able to make their own food, or do they need support with that? Are they just having cold food? Are microwavable dinners and things going to be helpful? Food costs, obviously, right now, and what food banks are available out there. That might be worried. And the safety over people cooking. Is somebody going to believe in the gas on? Are they going to be harming themselves or others with that? All these things to take into account. So we've got there 7 themes that assist people with eating and drinking with dementia. We talk a lot about person-centered, don't we? But it's really, and there's been a lot of questions about asking for us to be prescriptive about specific things. But it really is about individualized risk assessment, availability of food and drink that we have there. The relationship to others. Do people prefer to eat in a more social environment amongst others, or do they prefer to do that on their own? That consistency, keeping things at the same time, and also providing information to people that will go on to in a moment. I watched at lunchtime today, I watched our local news, the BBC Look North News. I'm from Yorkshire, if you haven't guessed. And they had on there this great item about these volunteers who had set up in this. They ran a cafe, but they set up once a week this like I don't know what they called it, but they had people with dementia and with their partners or carers or families that came along, and they do lunch, but then they do dancing, and they were felt really connected together, and it was just a joy to watch these people on the screen, and that reminiscence of music and dancing, you know. So it's all that type of thing that can be used in all the aspects of care through asking that we've been talking about today. And of course, you know, other challenges might be that somebody's wanting to wander or pacing up and down, just refuse it. Or somebody said they watched that at lunchtime today. Yeah, it was good, wasn't it? And so people refusing their food, or the apathy, indifference. But let's explore. Always put your Sherlock Holmes hat on and find out the root cause, because invariably there will be a root cause to the problems that's happening. And remember, if somebody's got other comorbidities aside of their dementia diagnosis, it might be COPD, it might be they've got gastro problems and like reflux, and certain foods trigger that, or exacerbation of something will then reduce their appetite somewhat as well. Next slide, please.
Ladies, I'm really conscious of time, and we've got so many questions. So I think if we can kind of speed up a little bit, that would be great.
This is very quick. So the last of the asking is just about giving information, and we're very good at, aren't we? We produce a leaflet, we'll give a leaflet out and things like that. I know working in the NHS, we did that a lot, but we don't want to use it as a tick box exercise, just that, oh yes, we've given that, because there are studies that have been done that say, actually, if we focus on that verbal and that the kind of the interpersonal relationship, to professional relationship even, of verbal communication with people, our families, their carers, that will actually improve, rather than just handing out a leaflet. Next slide, please. And but we do identify in root cause analysis that with a lack of giving information, it is often highlighted. But just top tips that we have, just talk slower, give people time, just be calm and communicate in short sentences. Don't, overload verbally. Don't talk to somebody as you would to a child. We have to have dignity and respect and inclusion. Keep somebody's sense of identity, break things down, and we can use humour. That's absolutely fine. But let's just be patient. Be patient. Don't be too sharp. Don't raise our voices. Don't get angry. Somebody is living with this condition, and we have to understand that. Right. Okay. So that's me done, and I'm not sure who I'm handing to next. I think it's Zena, just to finish us off before the final questions.
I think you're muted.
Just realised I'm muted. Sorry, guys. Yeah, I think the important thing is, as well, when we're sharing information, is to think about mental capacity and communication, and not to make the assumption that someone lacks capacity just because they may not be able to verbalise their needs as well as others, and perhaps they may have a hearing or sensory deficit that impacts on their ability to hear. But certainly think about how that means you need to involve family, and it's subject to consent from the person themselves. So obviously, if they have mental capacity and they don't want you to talk to their family, you have to respect that. But conversely, if you think it would be in the person's best interest to convey that information to their family, if you feel they lack capacity, then they can. And of course, people with mental capacity are entitled to make poor decisions or unwise decisions. So just because someone makes an unwise decision and they don't perhaps comply with some of the suggestions to reduce the risk, we can't enforce it on them. But I'm mindful we've got a lot of questions, so I think rather than go deep into the Mental Capacity Act, I think it's probably time to open up the floor, Emma, isn't it, for any questions people might have?
Absolutely, the questions are flying in. We really have sparked quite a debate. Okay, let's pick a couple. We've had some on the go. So for a resident with distressed behaviour and who has a pressure ulcer, we sometimes find they decline the dressing being changed. Any top tips?
I'd find out what's causing the distress first, because distress behaviour is not always, it's very rarely a symptom of dementia, actually. It's usually a sign of an unmet need. So is it about your approach? Is it about, are they in pain? You know, are you not conversing with them, and do they not understand? You know, are you giving pain relief maybe half an hour before you actually go and attempt to do the dressing? Is the person on regular pain relief? All of those kind of things. And again, where are you providing the care? I often see people taken into a bathroom where there's lots of mirrors, for example, and that can feel really invasive, because not only are there maybe one or two carers or staff with them, but there's also the reflections of the people in the room. So suddenly it becomes a very, very oppressive and uncomfortable environment. So, you know, think about those things first, but please always think about distress behaviour as a means of communicating an unmet need, and use it like that problem solving approach that Alison was saying. You know, be curious, think about, if I were in that position, what would be important to me? And as you start to chip away at those things, you'll find that that will make a real difference, and you might be able to reduce that distress and enable you to manage that person's care more effectively.
Just to think about the dressing type as well, because there are some with the lovely silicone type bordered dresses, which are very gentle removal and things. Because if you're doing the kind of stripping the skin, that's going to be very painful and distressing for somebody. So just think about the type of material of the product.
Thank you, ladies. Another question, possibly going to be a bit controversial, back to continence and incontinence. How can we as a group raise our shared concerns about prescribed pad suitability? They should look at suitability as well as looking at pressure management equipment suitability.
I think you're absolutely right. I think it is about advocating for the patient. So again, having a very strong rationale if you change your decision about prescribing, the same as you would with medication, for example. If you disagree with some prescribing regimes for medication, you have the right to challenge and say what you think the risk versus benefits are. And I think we should be braver in that. You know, it's saying what is best for our patients. And actually the guidance is pretty woolly, but there is guidance out there. There's actually a Delphi study, or a Delphi paper that came out recently on continence management. We've got the Alzheimer's Juris paper from 2016, which talks about the right products and the right approach for people with dementia and managing continence. But I think, again, it is about us pushing back and challenging and saying what we're advocating in the best interests of our residents and patients and those that we support. But it has to be done at most senior levels within ICBs and commissioning arenas, because it's actually often a budgetary issue, and we should be thinking first about patient care and quality outcomes. And I know that's not always forthcoming.
The RCN have got some good stuff on that, because that Delphi study, I did an interview on LinkedIn for Dr. Susie Orme, who led that study, which is on there. But the RCN, go on their page, and I think it's on there. There's a lot of stuff on there.
One last question then. Has anyone implemented Purpose T within their care? What's your thoughts on it?
It's a webinar within itself, is Purpose T. We've actually done it on Oscar, so you can have that link sent out and you'll hear all that. It's been pushed nationally as a tool of choice. It covers all service areas. I think it's personally great because it's not prescriptive. It doesn't work on numbers, you know, so what with a number? So, yeah.
Absolutely, I agree, Alice, and I like the fact that it's a RAG rating rather than numbers, and I like the fact it's got a preliminary screening tool, so you can screen out the people that are not at risk, and then you can focus in on those that are at risk.
Fabulous, thank you, ladies. There's so many questions. If we haven't answered your questions live, we will come back to you individually after the event. One or some of the nurses will make contact with you so that we can bring the session to a close. We have a quality improvement group on Facebook, which you're all invited to join. So as the slides come out after the event, the link is in there and you can ask to join the group. We celebrate pressure area care champions, as well as providing ongoing thoughts and insights from Oscar and the wider world of pressure area care. Ladies, thank you. Such a brilliant session again today. I hope that our audience have found some value and some interest in everything that we've talked about today. If we haven't answered your questions, again, please reach out to us. Use the email address nurse@oscar.uk.com, and one or some of them will get in contact with you. We hope you've enjoyed it and you can implement some of what you've learned in your day-to-day working environments. If we've talked about any equipment or you want to ask more questions around the alternating air and pressure relieving devices, then again, reach out if you'd like to trial it. We do offer those trials. We've got 2 other sessions coming up, one in June around around diabetes and pressure ulcers. And then again in July, we will be revisiting the darker skin tones and pressure damage. So again, 2 very hot topics. These ladies will be joining us again. Don't forget, today accounts for 1.5 hours of CPD learning. So we will be sending out your certificates early next week. And we have also recorded the session. So again, we will send the link so that you can go back and re-watch some of it. And as I said, if you'd like to speak to any of the nurses, reach out to us at nurse@oscar.uk.com. So all that leaves is for me to say thank you, ladies. Great session again, and looking forward to the next one. And again, audience, thank you for joining us today. And we look forward to welcoming you in June for our diabetic session. I hope everybody has a fantastic evening. Thank you.